I think it's rather appropriate that after you've just had your lunch and you're feeling quite soporific that I'm talking to you about anaesthesia. I'm probably going to finish off the job completely. So yes, we've been doing electrochemotherapy at James Cook Hospital in Middlesbrough for 9 years now. And what I want to do is share with you some of the things that we've learned about getting through the ECT procedure for the patients from an anaesthetic perspective. So, as an anaesthetist, we have certain concerns about the ECT patients when they pitch up on our lists. The first is that they often have a very poor state of health. There are well-known bleomycin toxicities that we have to take into account. We're going to use electrical pulses in the patients, and these may have some implications for us as anaesthetists. And the last thing is that we want to try and minimise the hospitalisation of these patients, because a lot of them have very limited life left. And if we can get them through this procedure with a technique which allows for same-day admission and discharge acceptably, then so much the better. So again, pulmonary toxicity is one of the ones that we're always very worried about, or we think a lot about at least. It's essentially an oxygen toxicity, and this is because bleomycin produces oxygen-free radicals in association with iron atoms. And these oxygen-free radicals are the things that cause the damage in the DNA. So this is what you want as from a chemotherapy agent. But it can also damage the pulmonary endothelium, and that provokes a pneumonitis, which eventually could lead on to pulmonary fibrosis. If you get it, it's likely to be permanent in 50%, but unfortunately it's fatal in some as well. And treatment is rather difficult. Traditionally, people have used high-dose steroids. And more recently, there have been reports of the use of tyrosine kinase inhibitors with some success. There are well-published risk factors, but unfortunately, the evidence behind some of these risk factors, if you delve more closely, is actually not very good. Perhaps the best is for total cumulative dose. Obviously, the higher the dose the patient gets, the more likely they are to develop a toxicity. But also old age, renal impairment, and this is presumably because bleomycin is largely excreted through the kidneys, radiotherapy to the chest, and at this point, the anaesthetist generally take an interest in exposure to the high alveolar oxygen that we've talked about already. Excuse me, and this was flagged up in the 70s when Goldner introduced bleomycin into his chemotherapy protocol for testicular tumours. Their practice was to give the chemotherapy and then wait 6 to 12 months and then do a retroperitoneal lymph node dissection, which in those days was a very big and bloody operation, which took about 6 to 8 hours or so. The first 5 patients they did after having introduced bleomycin then died of pulmonary toxicity, which looked like on post-mortem to be oxygen toxicity. So what they did then was decide to try and reduce the amount of oxygen that the patients were given during this procedure. They also decreased the amount of fluids the patients had, but the main intervention really was reducing the oxygen. The next 12 patients they published all survived, and then they subsequently went on to do another 200, which all survived without any pulmonary toxicity as well. So this is where the whole high alveolar oxygen exposure and bleomycin problem was flagged up. So you might think that, okay, well that's because you're using rather a high dose of bleomycin in these oncology patients, and we're going to be using a much lower dose. But from an anaesthetic perspective, what we're wanting to do with these patients when they come for a general anaesthetic is to give them lots and lots of oxygen. This is what we do. We try and give them oxygen to buy ourselves some time in case of airway problems. That's the traditional approach to putting somebody off to sleep. But if we're going to give a much lower dose and then give the oxygen at the same time, are we potentially going to have a problem? And there's very little in the literature, but there is something in the animal lab work which suggests that that might be the case. And this is a study by Hay and his colleagues where they took some mice, gave some of them some intravenous bleomycin in a decent sort of dose and saw no toxicity, gave some more high oxygen to breathe for a length of time, and they didn't get toxicity. But then when they did the two things together in a group of mice, they did get severe pulmonary damage. And their advice, based on this, was that if you're going to give intravenous bleomycin, you should avoid giving supplemental oxygen. This is lab work. This is not, obviously, human study. This is quite a nice study by Bloom and his colleagues. It's again from the 70s, but it's a big retrospective study of 808 patients where they considered that they'd got definite pulmonary toxicity. And if you look at what they elucidated, then at the top end of the scale where you're giving big doses, you've got a very appreciable toxicity incidence, but also a sizable mortality as well. Again, we're at the bottom end of that dose range in the 0 to 49, and you can see that 3% of patients develop some sort of toxicity. This is a long time ago, and conditions obviously have changed since then, but you might imagine that if we go on giving bleomycin to enough patients, then we're going to eventually see some pulmonary toxicity. And as we were talking about earlier on, there have been some cases of fatal pulmonary toxicity with the kind of doses that we are likely to use in electrochemotherapy. So we can't ignore this, I don't think. So I've put these things all together in a decision-making chart, if you like, when I'm trying to think about which patients I need to be especially careful about restricting perioperative oxygen. And the factors to consider down on the left there. If a patient is featuring largely in the green side, then I'm very relaxed about it. I don't think I'm going to have too much of a problem. But if there are a lot of red flags there, then I will be paying quite a lot of attention to restricting the amount of oxygen they're going to get. You can see on the slide there that I've got a separate row for route of bleomycin administration. As Tobias was pointing out, they tend to get lower doses. But there's some work that Tobias did with intralesional vascular malformation work patients where he showed that bleomycin was essentially trapped within the vascular malformation. You didn't get the same peak plasma levels. So if you're going to give it intratumorally for ECT, you'd expect that that kind of thing would happen as much, if not more, because you're trying to lock it in with the ECT compared with the vascular malformation patients. So how does this translate into our practice? First thing is, should you be doing baseline pulmonary function tests? And the answer to that is that what we do is DLCO for keloid patients and most of our BCC patients. There'll be some BCC patients who are just too frail, too old to comply with the testing, so there's no point in sending them off, we'll just delay things. We don't do baseline pulmonary function tests for the palliative work. Do we have to avoid pre-oxygenation on induction? This is a bit of an individual risk assessment. By and large, I'd say no, you don't. I don't think the risks are significant at all, just for that short period of time, and the benefits are potentially considerable. If the patient has an easy airway to manage and they're right on the red side of my decision-making table, then I would perhaps restrict oxygen on induction, but otherwise I don't think you need to worry too much about that. But during the procedure, you should be reducing the inspired oxygen, particularly if you're using intravenous bleomycin, and that's to a level of 30% or less. You know, it's easy enough to go lower than that in the vast majority of patients, but certainly aim for less than 30%. And if the patient's not going to have a general anaesthetic, it's just having sedation, most of our patients are just breathing air. So we've negated that issue. Occasionally, if you have a little bit of a problem with low saturations, we'd give some controlled oxygen via a venti mask. And continuing through into recovery, should you be avoiding hyperoxia in recovery? Well, yes, unless you have an airway issue, in which case you can just go ahead and give 100% oxygen as you normally would to deal with the problem. If the SATs are low, oxygen saturations are low, and this is not normal for them, then you can still use controlled oxygen therapy, and that's satisfactory. One other thing that we've racked our brains about over the years is whether or not we should be giving these patients a medic alert bracelet to warn subsequent anaesthetists. And we haven't as yet, and I think that's because A, we haven't had pulmonary toxicity, we're using low doses, and finally I think the risk in our normal patients, anyway, run-of-the-mill patients, of a subsequent anaesthetist trying to give a low oxygen anaesthetic inappropriately are probably greater than the risk of getting a pulmonary problem as a result. And we kind of backed up a little bit by that, by some recent work which has come from the hyperbaric oxygen enthusiasts. And what they shown, just a small study so far, is that patients who have previously had bleomycin some time ago can be exposed to hyperbaric oxygen for significant lengths of time without developing pulmonary toxicity. And their suggestion is that perhaps we've slightly overplayed this lifelong risk. So that's pulmonary toxicity. The next toxicity we need to consider is skin toxicity, and this is the most common one, and in, well, over, I can't remember how many we've done now, but certainly thousands of intralesional bleomycin treatments we've done. This is the only one we've really seen in any great numbers, and even then only about 5 or 6. And for the anaesthetist, the issue really is around the ECG electrode staining that you can get. What we think happens is that when you take the ECG electrode off at the end of the procedure, you get hyperemia in the pattern of the electrode. And bleomycin will then go preferentially to those areas and cause pigmentation preferentially in those areas. So what we do now, when we're concerned about cosmesis, is put the ECG electrodes in the axillae and on the sole of the foot, and you get perfectly adequate ECG trace from that. And if you were a skin marker as a patient, then you probably wouldn't even recognize that you'd had it. We also take the electrodes off using a solvent, and the electrode just lifts off. And since we've been doing that, we haven't seen any problems. We still occasionally do see pigmentation of scratches, and that's either because the patient has gone home and scratched themselves, or there's been a scratch during the procedure. When we do babies, often they'll kick their legs, and their name bands are sharp. You can get a little line of a scratch. And we had one patient where the baby pigmented in a line on the leg, and the mother was very worried about that. So now we wrap up their name bands with foam. This is not going to be an issue, clearly, for most of your ECT patients. And again, cosmesis from pigmentation of the skin is generally not a concern for a lot of the patients. But if you're doing keloids, or you're doing warts, I think you were saying, Joy, in George's there, then you should be thinking about electrode placement if you're going to put the patient to sleep. And this is the kind of thing you see. You can clearly see on the chest wall there, staining in the shape of an ECG electrode. You might say, well, is that going to be a problem? Maybe it will fade as she grows up. It may or it may not. And this is one of our ODPs who had bleomycin for lymphoma 16 years ago. And she was very keen to show me her flagellate scratching pigmentation, which she still has. And she has other lesions still over her body. Pregnancy. We pregnancy test all women of childbearing years for our vascular malformation work. But and that's because it's teratogenic in rats and causes abortion in rabbits and may cause congenital malformations in humans. There's very little evidence for that. But again, it's something you need to think about for keloid patients, your non-malignant ones, and the ladies who are still of childbearing years. Very easily to let it slip your mind. So those are the toxicities. The next thing is how are we going to be affected by the electrical discharge? And the main one, obviously, is muscle spasms, the intensity of which depends upon the stimulation energy. So we've talked about this already. If you're going to use the hex electrode, you're going to give much more energy than if you use a linear or a finger electrode. The depth of penetration is going to make a difference, and the proximity to major nerves and muscles will make a difference as well. So, not a surprise, but most troublesome is the area around the neck and the jaw. And with the hex electrode. And the hex electrode for us in Middlesbrough means a general anaesthetic in the vast majority of patients. And even under general anaesthetic, you have to consider the use of neuromuscular blockade to ameliorate the muscle spasms. Not everybody gets a spasm which is a problem. Some of them do. And obviously muscle spasms are the main reason for having to use sedation during the procedure, which otherwise could be done under local anaesthetic. So just to point out the problem of muscle spasms around the jaw, this is a lady that, well, actually Tobias showed the slide, who was having electrochemotherapy to the side of her face. And when we put her to sleep, we noticed that the tongue was protruding, interposing between the teeth and the eye gel. And if we had a spasm in the masseter there, she could quite easily bite her tongue. We have had one patient who did do that, not disastrously, but nevertheless it can happen. So we poked the tongue back in and I paralysed her for this procedure. Quick word about pain. Some of it has already been mentioned, and this is results from work done by a number of you in this room. The risk of peri-procedural pain is increased if it's patient's got pre-existing severe pain, and that seems to be the main reason for it. If you're going to use a high current, the area has been irradiated previously, got breast cancer, a large lesion, or if there are recurring treatments. And our practice is that if I think pain afterwards is going to be an issue, I'll give a gabapentin pre-med in quite a high dose. We'll very carefully infiltrate with local anaesthetic, and I'll bump up their opioids because a lot of the patients are already on strong analgesics. And in that way, we seem to manage quite satisfactorily. Okay. How do we decide which patients we're going to try and do under local anaesthesia and which patients we're going to give a general anaesthetic to? There's another chart. If the patient features largely over on the green side, then it's all systems go for local anaesthetic and sedation. If the patient is over on the right side for any particular reason, then that tends to mean the general anaesthetic. So just going down the column on the green side, if the patient's already had procedures done under local and we're fine with it, then that's a good sign. If you're going to use the finger electrode, which is lower energy and short electrodes, that's also good. Small areas, easy to anaesthetize with local, they're pain-free before treatment, and you're not likely to get muscle spasms. And a lot of our patients are now falling into that category because we're seeing more BCCs. And this is a breakdown of the type of anaesthesia that patients get at our institution over the last 3 years. And as you can see, to begin with, the numbers that we're doing is going up, but we're still doing around about half under general anaesthetic. As I say, the more BCCs that come through, the more likely that's going to swing the other way, and we're going to be doing very many more local and sedation techniques. So how do we compare to other places? This is the only published one that I could find, a quick look around. This is from Italy, where they are treating superficial metastases from malignant melanomas. As you can see, they do very few general anaesthetics, mostly are a sedation and local technique. But they're introducing ketamine into their sedation technique, and that's another league above your normal sedation. What we do is use target-controlled propofol. I set it up in the anaesthetic room, set it to run at between 0.8 and 1.5 mics per mil, let it soak in, wheel them into theatre, and then Tobias will start to put the local anaesthetic in. If the patient tolerates that perfectly, then that's probably good to go for the ECT. I might have to up it or down it a little bit. But that's all we use. Because I work with plastic surgeons, they're very good at infiltrating with local anaesthetic because a lot of their work is done under local anaesthetic. So I can rely on the fact that the area will be numb. And all I'm trying to do is ameliorate the surprise of the shock. So sometimes the patients will jump and they might even make noises, but by the time they wake up in recovery, they are very happy, very content, and importantly, not confused and are ready to go. Some other sedation techniques can leave patients rather befuddled for a while. So if you were to take those propofol ketamine ones and say that I would do those under general anaesthetic, then we're much the same. There are other issues that we have to think about regarding the electrical discharge from ECT. First is whether or not we can induce arrhythmias. Secondly, what to do about pacemakers and ICDs. And then one I found fairly recently is the effects on cochlear implants. This is going to be very rare, but nevertheless could be devastating. So when the ECT pulse is delivered, this is the kind of thing you'll see on an ECG monitor. It's an artifact and nothing to worry about. We have had one patient who developed an arrhythmia, and this was in the last few months. This is alternating left and right bundle branch block, which was subsequent to ECT pulse. You can tell, obviously, that I wasn't too worried about it because I had time to get my phone out and take a photograph of the monitor. It's a benign arrhythmia, and luckily it reverted into sinus rhythm again. However, she was a bit of a special case. She had a pleural effusion and a pericardial effusion. We were treating the right side of her chest. And you might imagine that the electrical pathways in that kind of condition might be different to normal tissue. Anyway, not worried about benign arrhythmias, but could you actually trigger a malignant arrhythmia, VF or VT? And this is quite a nice theoretical study done by Mali and colleagues in Slovenia, where they calculated the depth from the body surface, chest surface, at which you will get 100 milliamps current flow. And that's the threshold for VF. And in the best case scenario, using a linear electrode with minimal insertion, the depth at which you'd get that current is 1.5 centimeters. And the worst case scenario that they calculated was a hexagonal electrode, 10 millimeters insertion, and the depth for that current would be 4 centimeters. Is that a problem? This is a study done by radiologists looking at body mass index and distance of the apex beat from the chest surface, and this is centimeters along the bottom scale there. So we've got to look and see at 1.5 centimeters, those patients would be included. And at 4.1 centimeters, those patients would be included. So I think we do have to think carefully about using ECT over certainly on the left side of the chest. This is an ultrasound slide of one of Tobias's patients where he's treating the lesion at the top. The top of the slide is the chest surface. The less dense bit below is the lesion. The hyperdense bit is the rib, and below that we've got inside the chest. I don't know that you can actually see, but you might be able to see. Can you see at the bottom there? Wobbling away, and that's the heart. And you can see that's between 3 and 4 centimeters. So theoretically, with a hex electrode, we could pass 100 milliamps current through that bit of tissue, which is why we're now using the AccuSync. What we're wanting to try and do is synchronize the delivery of the ECT to the safe period, which is the QRS complex, and try and avoid the T waves, which are the vulnerable period. And here it is. This is what it looks like. ECG electrodes from the patient plug into the AccuSync, there, ECG in, and then that's linked into the clinicorator. And it will discharge the ECT pulse during the safe period. And apologies for the fuzzy slide, but there you go. That's ECT artifact on the QRS complex as desired. So we are using the AccuSync much more regularly than we used to. What about the implantable devices that I mentioned earlier? Well, pacemakers, generally speaking, you leave them on and check the pacemaker after the procedure. The worst case scenario really with the pacemaker is that the pacemaker will sense the ECT pulse and then not pace, so the patient will miss a beat, but it will pick up again after that. If you discharge very close to the pacemaker, you may put it into safe mode, which actually won't cause much in the way of problems at all either. But you do need to make sure that you do a pacemaker check after the procedure. ICD is a little bit different because you have to turn them off. If it senses the artifact, it can discharge. And if it discharges, the patient will get another jolt on the heart. It may even trigger off another VF. So you turn them off, have the defibrillator standing by, but remember to turn them on again afterwards. Cochlear implants, they're very, very sensitive to electrical currents. And there's no guidance with ECT, clearly, but you shouldn't use bipolar diathermy within 2 centimeters of the implant, nor monopolar diathermy above the clavicles. So if you happen to have a patient with a cochlear implant, then give this some careful thought before you use ECT in that area. Just to show how robust pacemakers and ICDs are, this is a study where they had probably enormous fun testing tasers, and they showed that even with tasing pig with pacemaker and ICD, they couldn't damage the devices. So lastly, a word about future possibilities for anaesthesia for this procedure. There's an agent which is being released into the country round about now, which has been used for quite some time in Australia and New Zealand for acute pain. It's an old-fashioned volatile agent called methoxyfluorane, which is intensely analgesic and partly sedative as well in low doses. Even got into the Daily Mirror, and comes as an inhaler, which is self-administered. The patient breathes away on that until they've got some effect. You do the procedure, and then they stop breathing on it. This is a paper from Anaesthesia just recently, where they used methoxyfluorane for burns dressing changes with some success, and then went on to use it for minor surgical and radiological procedures in quite a number of patients with a 97% success rate. So this, in combination with local anaesthetic, could be something which could be useful for us in ECT. So in summary, anaesthesia for ECT is to some degree bespoke, and one technique will not apply to all patients. You should take account of the toxicities, the effects of electrical discharges, and be consistent with day case admission and discharge. Obviously, it should be acceptable and repeatable. Thank you very much.